harm reduction itself is a really holistic approach. So instead of telling people you're bad, stop doing drugs, you gotta quit right now, and go cold turkey, it really approaches people like a mother. Try to understand what they're going through, and try to work with them to make healthy choices.
Hi, everyone. Welcome to another episode of RxRevolution. I have Dr. Terry Church here. If you wouldn't mind giving us a little bit of an introduction about yourself.
Sure. So I'm Terry Church. I'm in the Department of Regulatory and Quality Sciences, part of the School of Pharmacy and Pharmaceutical Sciences here at the Alfred E. Mann School of Pharmacy. I'm also the co-director of the education program for the Institute for Addiction Sciences. I am our director of undergraduate research and undergraduate education, and I've been with USC now for 15 years, but I've been faculty for 7.
Very cool, very cool. You have a long list of credentials, which I love, which makes you the perfect person to have this conversation with. I think we should get started with talking about, well, first of all, our topic today is about illicit drug use and harm reduction. What is illicit drugs?
Ooh, that's a tough question. So the best way to think about it is we're pretty familiar with things like over-the-counter drugs, where you go to the pharmacy and you can purchase it over the counter. And then we have things that are over the counter but behind the counter, so things like Sudafed and other similar things that can be adulterated, meaning changed into something nefarious or somewhat nefarious. We'll talk more about that in a moment. And then you have prescription-based drugs, which you have to have a prescription from a health provider to be able to fulfill the need. And prescriptions have only been around for a little bit of time, only since 1951. If you would have gone into a pharmacy in 1950, you could have purchased heroin over the counter with no problem.
Whoa.
Just to give you an idea of what it's like. And that's also before the Controlled Substances Act. So heroin was still available in smaller dosage forms in most pharmacies in the US. So the idea of licit, meaning, with the law, or illicit against the law, is something that's relatively new since the 70s, give or take. But dating back to at least the 30s with the start of the prohibitions against cannabis, and then following that, you had cocaine, and then following that, you had opioids. And it's just been a long litany of things that are under the Controlled Substances Act that would be considered to be illicit. The biggest problem today with those illicit drugs is the fact that they're being manufactured in clandestine labs. So anyone with a little bit of chemistry knowledge can go in and say—
Breaking Bad.
Breaking Bad, definitely. And they can say, all right, today I'm going to make this compound, which there's some problems with that, right? I mean, there's no quality control.
Right.
There's no FDA that's overseeing the processing or the manufacturing. So it's literally being made in a bathtub with chemicals that may or may not be pure. And the end product may or may not be pure. And then to add even more insult to injury, it gets adulterated or cut, as they call it on the street. So fentanyl is a big problem right now. And just to give you an idea, since the beginning of 2024, here in the state of California alone, a task force that has been set up by the DEA as well as the state has seized nearly 7 million fentanyl pills and about 3,700 pounds of fentanyl powder that have been marked for street sales. So
I'm sorry, that number is staggering.
It's huge, and that's just one drug. We're not looking at things like methamphetamine, which is also a huge problem here in Southern California, or cocaine.
That's insane. And well, I kind of want to go back to the heroin in the 1950s that you can get over the counter.
Oh, yeah.
Like, what's an interesting tidbit? Like, what were people using heroin for at that time?
Oh, a variety of things. So heroin came in a 2-pack. So you would get aspirin and heroin sold in the same package. And I used to think that, it was when the heroin wore off and you had the headache, they were being brilliant about their marketing, providing you with the aspirin to be able to cut that headache down.
I mean, heroin in one packet and then aspirin another. That really wasn't on my bingo card for this year. Can we talk about what are some current trends in illicit drug use? I know you mentioned fentanyl on the street, methamphetamine. Can we talk more about what are the trends with that stuff?
Sure. So California is, in a way, a melting pot for drugs. It seems like anything that people are going to use or abuse, if it's not in Florida, it's here. So Florida, they do have their history with things like zombie.
The cocaine cowboys.
You got it. Or drugs that turn you into an absolute zombie where you want to literally bite the face off of someone.
That was on the news.
That was on the news. But Here in California, it seems to be more focused on opioids and amphetamines.
Okay.
To the tune of the methamphetamine problem, last year, I believe the DEA seized almost enough to equate in weight to 75 adult male elephants. So if you can conceptualize that, that's a huge number. And when you think about crystal methamphetamine, it's not that large in terms of what it looks like when it's in its sold street package. So 75 adult elephants, that's huge. And that's the amount that was confiscated in just 1 year. California does serve as a distribution hub, unfortunately, just because of the ports that we have to the Pacific Ocean, and also our border with Mexico, where a lot of these things are being manufactured and then brought across the border, which is another issue related to harm reduction as well, because people fall into the trap of becoming drug mules, moving things across the border, unfortunately, sometimes because one of their family members have been kidnapped or because they're paying off a debt for a family member. And it just so happens that it's mostly women who are falling into that trap.
Yeah, unfortunately. And they have to pay the price for their family members, or sometimes they just want to get here because that's just the means of how they can get here. And it's so unfortunate. I mean, there's so many systems and systemic things that we can do that's surrounding the drug problem that we currently have. But it's so many things, and it's just like, where do we start kind of thing. I want to talk about, we know what it kind of looks like when we see people use these drugs. What are some of the impacts? Like, who are the people that are susceptible to the addictive properties of these drugs, and what are we looking for, or rather, like, what do these individuals look like, and what do they look like when they're on these drugs?
Ooh, so that is a loaded question.
I know.
I'll try to unpack it for you. So I tell my students this all the time when I teach. There are two diseases that every American family will face in their lifetime. And the first is cancer, and the second is drug abuse. Every American family will be touched by it in some way, shape, or form. Who is the typical prototype of what you think of when you see someone in your mind who you think of as a drug abuser? Is probably someone from a comedy show that you've seen.
True. A soccer mom.
But really it could be anyone. It could be your grandmother, it could be your mother, it could be your best friend, it could be even a teacher or a mentor of yours.
And I think that's a really good point to make, because I think we have this idea of the image of who uses these drugs. And I think that's also perpetuated by the media, of like the face and the people and things like that. But what we fail to understand is that drugs affect everybody.
Yes. And unfortunately, depending on what your socioeconomic means are, you have a way that you can function in a stabilized manner and be a functioning addict, or you have no money to be able to support that, and you fall into the trap of the stereotypical drug user.
Yeah,
unfortunately. And homeless individual.
Yeah. And so, like, what are some of the socioeconomic costs of drug addiction? Like, I know for individuals who are using these drugs, obviously, you know, some of the prices that they have to pay are they lose their jobs, they're now homeless, they're possibly living on the street, they're doing things that are not healthy to obtain these drugs. But like on a society, government level, like what's the cost?
So just as an example, Oxycontin use costs you about $4,125 a month to be able to support your habit. So that's just one number.
Wait, 4,000? Say that number again.
$4,125 to support your habit. Okay. If you are a heroin addict, you're spending anywhere between $250,000 to $275,000 a year to support your habit. We also see in states that have legalized prostitution that 3 out of 4 prostitutes are addicted to a substance. A part of that is escapism. You know, nobody falls into it and says, today I'm going to be the best hooker I can be.
Right.
There's usually some catalyst that gets them into that situation, and the only way to either get them out of it mentally is to use a substance to remove themselves from the situation, or they're having the substance being used on them as a way to control them. So there's a lot of problems wrapped up with it. The biggest problem, though, is the fact that we do prescribe very heavily into opioids, oftentimes where we don't need to, but who's done the research to say what a good alternative is, and who is available to say what your pain level is? I mean, you as a budding pharmacist should know how we test for pain. Do you know how we do it?
Remind me.
So it's smiley faces. Are you sad? Are you okay? Or are you happy?
Ah, yeah.
And that is our method for testing for pain. Just because pain is so arbitrary. I'm a wimp, so if you were to kick me in the knee right now, my pain level would probably be 1,000,000. Whereas others, you might kick them in the knee and it's only a 5.
Yeah.
But people have learned how to exploit that, and they've learned how to manipulate the system to get a constant prescription of opioids. And if they don't have that prescription, what we find is that they end up turning to street drugs, to drugs that will give them the same thing.
Yeah.
Yep. Unfortunately, the trend used to be that you would start off as a heroin user and then transition over to a prescription drug user. But what we see more frequently
is the prescription drug user going into the heroin and then street drugs. Wow.
Exactly. With an unprecedented rise. I mean, you're looking at maybe every 8 out of 10 individuals who start as a prescription drug user end up doing a street drug.
Yeah. And I mean, pharmacies like the ones we know are going bankrupt because of this same problem. They were peddling these drugs to people, not really realizing or quite frankly, ignoring the problems that were arising in these patients.
Oh, definitely. And then if you add into the mix, gender and then people of color, it's a whole different spectrum.
Correct.
Because they look at the level of pain being differential across gender as well as across skin color, which is completely erroneous.
Yeah.
But it is something that people have to contend with when they go into the clinic.
I know. And it's like it doesn't, I know in the history, and we're going to talk about racism, but there were plenty of physicians way back when that thought that Black people had a higher tolerance to pain. I mean, the godfather of OBGYN used to mutilate his patients and then gave the white counterparts anesthesia based off of the pain threshold of the women that he was testing these instruments, these procedures on illegally and always without their consent.
Always. And with any regard to their health or well-being, kind of a very vile practice that he was doing for sure. But it's not a singular case, unfortunately.
Right.
In history, it keeps repeating. So hopefully we can end that
right now. Yeah,
yes, right now.
I agree.
But I think that got us a little off topic.
That's okay.
Back to this idea of harm reduction, if you don't mind. So harm reduction itself is a really holistic approach. So instead of telling people, you're bad, stop doing drugs, you got to quit right now and go cold turkey, it really approaches people at the level where they're at. You try to understand what they're going through and you try to work with them to make healthier choices. You know that they're not going to quit today. So how can you help them approach their drug abuse in a way that is more healthy, more thoughtful, and over time build a relationship with them on a one-to-one level where you might be able to get them into care or into a facility that would be of assistance to them.
Yeah.
And that's the big issue people have with harm reduction. They don't fully understand what the approach or the process is. And all they see is, for example, if you go back just a few years ago, there was this whole news bit about Biden giving out crack pipes as harm reduction to people. And it was all over the news for a couple of months. And it was an issue that really was highlighted by the left saying, look what he's doing with our taxpayer dollars, without taking into account the fact that, yes, there was a program designed for that, but the idea was to get people to be more healthy about their drug use and along the way start the conversation to get them into recovery.
Yeah, and I feel like the harm reduction, when you're not really using harm reduction and you're probably using another term, I think people think it's such a controversial topic to give people who are addicted to these drugs, but in an environment that's controlled, safe, and under the supervision of clinicians who know what to do, and then in the event of an emergency, know how to alleviate that said emergency.
Yes, and that, it's a broader approach that we do today than we had many, many years ago. Unfortunately, the war on drugs had a huge toll on how we do this type of harm reduction. It made harm reduction a bad word in the halls of Congress and also made it unfundable. So prior to the war on drugs, about 1983, we had a federal program that was funding harm reduction and needle exchange. And then the HIV scare hit in 1985-ish, around there. And it changed the way that we looked at drug users and people who used injectable drugs in particular. That also changed the paradigm because the war on drugs now required two things. The Surgeon General said, we'll fund you, but you have to prove two things. One, that your program is reducing the number of people who are getting HIV. And two, that you are reducing the number of people who are becoming drug addicts. Two unrealistic ways of looking at it, because one doesn't equal the other.
Correct.
So this harm reduction program doesn't equal stopping of drugs. This harm reduction program doesn't equal stopping of HIV. It is just a method by which we can make sure that people are healthy and aware of what could happen to them along the way.
Yeah.
So it cut all funding, and a lot of these programs were funded by grassroots efforts, people going out and actually doing fundraising and campaigning. But then you run into the problem of, in the American psyche, you now have the harm reduction program with needle exchange equated to another drug distribution channel. So people are saying, we don't want that in our neighborhood, you've got to stay out. And these vans that people would purchase to drive around from neighborhood to neighborhood to do the exchange were often targeted. It was a pretty scary place to be in the 1990s, to be honest. But it has evolved and it has changed and morphed. And here at USC, we participate in what we call street pharmacy, where we actually send people out to do this type of education as well as outreach. And it's had a really positive impact here in California, for sure.
Let's stick a pin in that, because I do want to come back to what USC is doing. But first, I do want to come back to the topic of war on drugs and what it did to society, and in particular, what it did to inner city people, and like how it led to a mass incarceration because of the fact that even such a little bit amount of drugs, you're going to jail.
Definitely. So we've had two wars on drugs, to be honest with you. So the first one was started in the 60s by Nixon, not as glamorized as the one in the 1980s, but Nixon did a few things. He made sure that the DEA was enacted. He gave them the Controlled Substances Act to work with and the scheduling of drugs. So he set all of that into motion. He also set aside and earmarked almost $3 billion worth of educational and outreach funds to help people who are living with addiction. And that sadly was not tapped into or used appropriately. And, you can say what you want about Nixon. This is his one saving grace, was putting this into place to help people who are addicted. Fast forward to the 1980s, and it becomes kind of a joke, a running epithet of the era.
Yeah.
And you start to see this rise in concern over drugs. Every baby that's being born is a crack baby now.
Right.
And really around the high watermark, no pun intended, of 1985 is when crack cocaine really systematically hit every major urban center in the U.S.
Yeah.
And we're not sure why. Everyone has their own speculation and rationale behind it, but it did impact specific areas. And those areas were urban centers where people were leaving because of job loss, leaving because of lack of funding, jobs, and also food. So people were just leaving, and by people, I mean those who had the means to do so.
And those were probably typically people that were white.
Yes, for the most part. And people who were left behind in the neighborhoods as it starts to decay are people who are entrenched in the area, people who don't have the means to move. And unfortunately, it happened to be people of color who became that group of isolated individuals. Let me ask you a question.
Yes.
If you were going to open your own drug cartel, would you want to do it in the affluent middle-class neighborhood, or would you do it in an area that's low cost, low potential for people becoming involved?
Definitely the low-cost area, yeah.
Karen doesn't live there, right? She's
No.
not going to call the cops if anything goes out of whack, or if there's a huge party or people are coming. If you do it in the outlying neighborhoods that have money, obviously somebody's going to call immediately.
Oh, absolutely.
So there's already this built-in structural violence that's occurring without even looking at it, because you're in a neighborhood that's depressed economically, you're in a neighborhood that's depressed in terms of education, and people are already on edge. They're less likely to call the cops because they don't want retaliation.
Right.
So it sets the stage for this perfect balance of drug distribution networks. And unfortunately, that's what happened. To further add to that problem, in 1985 to 1989, if you look at the statistics from CDC, what you will see is an increase in infant mortality among people of color,
right,
especially as it relates to being in an urban center. Black males ages 18 to 21 saw almost a 35% increase in homicide rates in 1 year alone.
Yep.
And if you take it even further back to about ages 13 to 17, a 75% increase in homicide rate.
Wow.
You had lack of access to any type of medical care, lack of access to pharmacies, and very little education.
Right.
And put yourself into the shoes of someone who lives in that neighborhood. It's very depressed, there's no opportunity, and you're sitting in a classroom that isn't funded. The teachers probably don't really care that much. They're not teaching, and you look out the window and you see your cousin out there with the best, newest ride that you could possibly imagine, the best sneakers.
And you want to be just like them.
And you want to be just like them.
Because you don't really have the guidance, especially from home or even in the school system, to keep them in the school. You know, there's no extracurricular activities. They don't have basketball. They don't have soccer. They don't have after education programs to help them with homework. Those things simply don't exist.
Yes. So why sit in that room when you could be out on the street making money?
It's more alluring. It's like, I can make money by doing this, and then now you just perpetuate this cycle of drug abuse, drug using in this community.
And that is how structural violence works. There's no one you can really blame for it.
Right.
It just happens because of the way that the systems, both economic and cultural, function, but it perpetuates itself.
Absolutely.
And through that very image, it's self-fulfilling. It's now moving that potential student out onto the street to become another person in this war on drugs.
Right.
So the other catalyst for this was the fact that we had the same drug now available in two different formulations, and one is seen as being more high class and the other is seen as more low class. And this is cocaine. So cocaine was seen as, you know, part of the disco era. If you were affluent,
yeah, Studio 54,
you got
that.
If you were part of the know, you were in the cocaine scene. And then came along its more unrefined, undignified brother.
Cousin, brother.
And it's super easy to make. All you need is equal amounts of sodium bicarbonate, water, and cocaine.
Baking
and you
soda,
boil it all together and boom, that's it. But it stretches out the drug's potency. It stretches out how long it will stay in your system in a way. Because now you're inhaling it, you're lighting it, and it has a short duration. Whereas the cocaine has a duration of about 60 to 90 minutes, depending on impact. This has even less. So it's about 30 to 40 minutes.
So that
30
would
to 40 seconds.
Essentially make it more addictive, because since the duration is so short, you kind of want to get another hit because it didn't last that long.
To keep that high perpetuated.
Yeah.
It also means that you can sell the product at a lower cost and people will buy more of it.
Right. Oh, that's even worse.
So that's even worse. And the problem became you have cocaine being used by the upper class, middle class, and crack cocaine being used by the lower class.
Right.
And a law became enacted for this one drug. It's called the 500 to 50 rule.
Okay.
So 500 grams of cocaine is enough to get you sentenced for 7 years, and there's also fines that go with it. You only have to have 5 milligrams of cocaine to get the same charge.
Wow.
So in these open-air drug markets in the urban centers, it's mostly people of color, mostly young Black men who are out there. Not only do they have guns, but they also may have a small amount of this drug on them. If they're caught,
immediately going to jail, which led to the influx of incarceration of Black males. And so it's just a testament as to what are we really doing? Who are we really helping? And how do we actually do it in a way that's equitable to everyone?
So there is a silver lining to this. I don't want it to sound like all doom and gloom.
Right.
But we found that the best way to correct this problem and get the communities back engaged was to go to the Black leaders in the community. So people who were in charge of religious services, people who were in charge of community centers, and we provided them with the means to be able to begin to take back their neighborhoods, which they did. But that problem from 1985 to 1989, where you saw an increase of almost 250,000 young Black men being arrested, facing life sentences, changed the demographics of the inner city.
Absolutely.
And also altered the lives of everyone involved.
Oh, yeah. Oh, yeah.
With no, we're sorry for your luck, or, sorry that happened to you, no apology whatsoever from the government. And instead, we look at them as being criminal and as being the worst of the worst.
Right. And then unfortunately, they become the face of the drug problem.
Yes.
And so then as a society, we view the drug problem as a Black thing, as a urban thing, as an inner city thing, when quite frankly, like, I'm from Long Island. Like, when they introduced Naxalon, we weren't in the parts that were impoverished, or we weren't in the inner city. I was in Long Island. I was with moms who have children in private school. I was with the parents of children who were going to Ivy League colleges, and they didn't look like me, but they were the people that were targeted for this specific preventative measures, because at the time, especially in Long Island, a lot of the times they were the ones that were using those kind of drugs.
Oh, yeah. So one of the things that really gets me excited in terms of research is street capitalism. Mm-hmm. Why does this function? Why does this continue to occur?
Right.
You would think, with a market, okay, let's say you're a drug dealer. Mm-hmm. You have drugs, you have the guns, you have the money, and I'm coming to you to purchase something. What's to stop you from stealing my money and not giving me any product?
Nothing.
Well, an economy forms. Mm-hmm. So if you do that to me, I'm going to go tell all my friends who do drugs, hey, don't go
right,
here.
Right,
You're going to
right.
get bad product. They're going to steal your money. So it begins to equalize itself. So it creates this system of economic checks and balances without even having any type of oversight. It is the craziest thing ever. But part of that street capitalism is the fact that you now have people who are making tons of money with all of their young peers watching that and wanting to emulate it.
Right.
And it falls back into that same pattern.
Same cycle.
Yep.
Yeah.
So I want you to think for a moment about two drugs. So the first is crack cocaine.
Okay.
What images come to mind for you when you think about it? Images that you may have seen in the media. And then I want you to think about opioids. And what type of images did you see?
Two different images.
Definitely.
Two very different
images. So the first, I bet, was either a Black male or young Black female. Usually it's black and white. It seems very harsh, very desolate.
Yes.
Like all hope has been lost, right? Whereas switch it over to the opioids, which is seen mostly as a white problem.
Yep.
Now you have this idea of redemption.
Right.
Of the need for repentance.
Right.
A savior that needs to come and save them from their ill, being naloxone.
I know. And so the thing about that too is the fact that when you were telling me to like picture the image, and then I immediately went to like the crack baby advertisements. You would see like a Black baby who was probably born prematurely, hooked up to so many cords, and then you look at the opioid and you'll have this you'll see the before and then you'll see the after. You don't really get that for the crack, and then you'll see that they're doing better or that they're trying, and then they have the familial support, their families behind them.
Yep.
They probably went to rehab, they have all this intervention, and it's like you're not getting that for the other image.
No, and let me add a little more flavor to that. Did the opioid baby get taken away from his mother?
Absolutely not.
No. Did the crack baby?
Absolutely.
Yes, and that created a whole system of really awful parenting, because you're taking children away from their mothers. You're creating this system that really demoralizes people along the way. And it really uprooted a lot of families.
Yes. I want to bring up, there's a topic, there's an article in the New York Times, it was printed in 2009, but they were talking about the effects of cocaine on pregnancy and infants as opposed to alcohol and tobacco use.
Yes.
And they were saying that, which I found so interesting, was the fact that while there are subtleties in changes, they weren't as big as if in comparison to if a parent or a mom was using alcohol or tobacco during pregnancy.
Definitely.
And that just brought up the topic about cocaine use in, these individuals being more of a moral issue rather than something that can be changed or a problem because they have, they're addicted to this drug.
Oh yeah, no, you hit on it 100%. So it is called the moral panic of the 1980s for a reason. There really is no substantiated evidence. If you think about things like the Just Say No campaign, that was funds that were available. So they grabbed those funds and ran with the craziest thing that they could come up with, which was Just Say No. And it just so happens that the First Lady jumped on that and made that her bandwagon. But you had similar companies that were doing it, and they were creating videos and all of these tutorials that could go out to parents and others, warning about the dangers of drugs. And in there, I can remember seeing one from the 80s where there was this group of kids who were at a sleepover. And one of them went in to make popcorn, and they thought it would be funny just to sprinkle all this crack cocaine on top of the popcorn and then take it back into the party as a way of saying, look, it could be in your own home and you don't know it. But it was all white kids, which made it really, really awful. So the really bad part with this whole moral panic, if we go back to that same article, which referenced CDC data collected from, I think it was 1983 to 1989, if I remember right. It looked at a variety of different categories of addictive substance and outcome for the parents. It rated alcohol as having a 65% chance problem, meaning if you were doing alcohol at that time, 65% chance that your child would have some type of disease. Followed by tobacco, which was, I believe, in the 50s, followed by crack cocaine all the way at the bottom at 2%.
Yeah, it wasn't even that high.
No, it wasn't, but we were hoodwinked. We were
bamboozled.
led to believe, we were bamboozled 100%. We were led to believe that it was a much larger problem than it was. And I don't want to degrade it by saying that no, crack cocaine isn't a problem for pregnancy. It does have some effect.
Right.
But we don't have a good handle on it. We don't have enough data to say every single person who has been exposed to crack at the first trimester, this is what their pattern is going to be.
Not in the same way that we have fetal alcohol syndrome or we see the babies born with defects because their mothers ingested tobacco.
But do we persecute those mothers? Do we go after them if they smoked or if they drank? No, not at all. It's culturally acceptable. Whereas crack cocaine is not.
Is not, correct. I want to shift the focus a little bit and come back to USC. You know, the title of our podcast is RxRevolution. And so what can we do at USC, or what is already being done or implemented, you know, to kind of counteract these issues? I know you mentioned that I even know that they went on Skid Row for street pharmacy. Let's talk a little bit about that.
So there are a number of really great programs. I want to start with the student the student built programs. I think because for me that's a very inspiring thing to see students taking over and really giving in.
It was beautiful.
It's amazing. So one of them is an undergraduate program. It's called TACO. They've changed their name recently, but it used to be Trojans Against Combating Overdose. Oh, no, Trojans, I forget what the A was, but whatever. We'll figure that out. But it's a group that started here, grassroots, and it's now available in almost 32 different universities across the U.S.
That's awesome.
They hand out test strips for fentanyl. They do videos, and they talk to their peers, peer-to-peer, about the dangers of different alcohol, substances, and a variety of other life situations. Also mental health concerns. So it's a great organization. They're available on campus. Moving from that to an undergrad/grad program, which is street pharmacy. It's led by physicians from Keck as well as people from here at the Mann School. But it really is intended to take to the streets what people need, whether that's diagnostics, whether that is some type of intervention. They're doing it, and they're making sure people are getting education and living as healthy as they can, while understanding that you're not going to cure them of their addiction today, but you may have an impact down the road. And it's a great group, and they do a lot of really cool things. And I believe that as a pharmacy student, you can actually participate and volunteer if you want, and go out on this service.
I think I need more information about that, because I think it was during orientation or maybe during a class in P1, we saw a video about a pharmacist going out on the street, and it was inspiring because a lot of times people are scared to go out on the street. They're scared to talk to the unhoused. They're scared to talk to individuals who may, you know, quote unquote, look crazy. And so I think it's so important that we highlight the fact that, you know, we're actually doing this work. We're actually going to the street. We're actually getting in touch and going at a face value at with these individuals to connect with them, to teach them, to, you know, at the bottom line, just straight help them.
Exactly. They're still people.
Yeah.
And we need to remember that and treat them as we would want to be treated ourselves.
Correct.
You know, go back to who you think of as the drug addict. If that was your grandmother out on the street, would you want somebody to help her out?
100%.
Definitely. So same attitude you should take into it if you go into the field. There's also a lot of research that's being done here. So we have Dr. Davdimov, who is doing some amazing work. He has brought into our use test strips everywhere, and gives them out freely for people who need to use them. I think that as a pharmacist, when you go out into the field, you need to be aware that these things are occurring.
Absolutely.
And if you are prescribing opioids, maybe talk to them about getting naloxone at the same time and getting trained. You know, you used to have to be trained in how naloxone works, but it's becoming more and more accessible. It's also becoming something that you can find in vending machines, like here on campus, where you can purchase it and use it if need be.
Which I think is great. And I wanna talk about in doing this, in pharmacists, student doctors, you know, going to the streets, how will this create equitable drug policies for the future?
Another big question. What I would like to see is that it slowly changes people's perception and makes them understand that addiction isn't as cut and dry as we used to think of it. And we can't think of the addicted person as being the bad person. You know, just say no did a number on all of us, because if you were that individual who didn't say no, guess what? You're not American. You're not worth our time.
Why did we
You're
do
not
that?
Healthy. And you were weak because you couldn't say no.
Right.
And we needed to get over that mindset. So as a base for the policy, I think that's a great way to do it. You're getting exposure, you're getting to see people as they are and understand that, you know, it is an illness. It is something that we need to treat from different vantage points. Most of these people have co-occurring disorders. It's not just their addiction. It's usually some type of mental health concern. Could be another disease as well that's influencing their use of these substances.
And so like I'm from New York, and we have a unhoused population in New York, not as severe as I would say that's here in LA or California on a whole. But, you know, a lot of times when I would like maybe volunteer at a soup kitchen or talk to these people or even ask them if they want any food, something like that, a lot of the times you find that they have been veterans in the war who had to take pain medication because they had their leg amputated and then they got addicted to the drugs. Or oftentimes I would encounter people who had a mental illness. They were taking these medications for whatever reason, and then now they got addicted to the drugs and they ended up on the street. So I think we still need to characterize this addiction as an illness, and I think that's not the complete visual that we have as a society. I think we definitely look at these people as the problem. We definitely see them as someone who is like an untouchable, they don't belong in society, when in fact they're human. How do we reintroduce them to society? What are the things we can do that will help, which we can segue into the facility that has been established recently. Let's talk about that.
Oh yeah, so in Chelsea, which is a very busy area in New York. If you're not familiar with it, educate yourself. It's got some of the best food.
Oh yeah, shout out to New York.
So go check it out. Back in the day, I used to hang out in Chelsea quite a lot before I moved out here, but it's a unique neighborhood. It's transitioning, and I hate saying that because every neighborhood is transitioning, but it's one of the few that you can feel the change. So it used to be very chic and very trendy, and you know, people wanted to go there, and then it kind of fell into disrepair, and now it's on the rise again. But they have decided to make that the staging ground for a clinic that you can go to that is staffed by a pharmacist, a physician, and a PT, OT. And sometimes you have an NP there. It just depends on who's available.
That's awesome.
It's staffed by people from Columbia as well as NYU. And they are there to make sure that you have a safe space to go and inject your drugs. And you might be thinking that sounds really odd. Why would professionals want to do that? Well, there's a lot behind it. Again, going back to the very beginning of the conversation, these things are being cut. They could have a lot of fentanyl in it. Could have a lot of really bad products in it.
And you don't need a lot of fentanyl to overdose.
No, it's less than the amount of a grain of sand to be able to overdose. But there are also other products that get adulterated into these street drugs. Having someone who's trained and able to treat anything that would happen immediately is a godsend. If you look at places like Philadelphia, where they have open air shooting galleries, in Kensington, for example, you see dead people laying on the street overdosed quite frequently. And imagine that if that's the neighborhood you live in as a child and you're walking home from school and, oh, there's another dead body from overdose. It's not only bleak, but it also solidifies this idea that, you know, drugs are really bad. And they are. Don't get me wrong on that. Drugs are also really good. We do some amazing things with them, but we have a propensity as human beings to use things to the nth degree. And as Americans, we like to take that even further.
Further, correct.
If we can supersize, we're going to supersize, right? Same thing here. But this type of clinic makes sure that people are getting education, they're getting access to clean needles, and if there was a problem, they were treated immediately.
Yeah.
So it's cutting down on the amount of death from overdose, but it's also hopefully educating people. They also operate support groups. They operate food drop as well, so people can go and get food there. They don't have a live-in facility currently, and they don't have housing for homeless, unfortunately, but it is a safe space.
It's a work in progress also. So it's one of the first facilities,
yes,
and which I think is so important as we talk about the education portion of it, because I feel like even healthcare providers, we're not exempt. I feel like sometimes we also have those views when we see patients who are coming in high to the ER with whatever ailments. We look at them in the same way that we would see them on the street. And I feel like having these facilities and having healthcare providers working in these facilities changes the narrative around these individuals.
Yes. And as a healthcare provider, you have to get out of that mindset of, I'm only going to see patients who have insurance. Right. Or I'm only going to see patients who have this type of Medicare insurance. Right. You have to get out of that mindset because these people won't have insurance. They're at their extreme, and we need to be able to assist them. But this whole idea of it being a morally funded or formulated problem is very, very real. And sadly, the way that you see people and the way you see the world is going to color the way that you see your patients.
Absolutely.
And if you're not cognizant enough to really appreciate that or reflect on that, you're going to continue in the same pattern.
Absolutely. We're almost ending the podcast as we're drawing to a close. I really, really enjoyed the conversation. I think this was very thoughtful. I think it's very illuminating, and I hope the audience feels the same way that I felt. You have so much knowledge about this topic. I think you are the perfect expert to have on this, and I'm glad that we had the opportunity to talk about this. And I think we as USC students, we should get a little bit more involved with these initiatives, especially the street pharmacy, how we can maybe volunteer more, how we can have more face-to-face with these individuals to kind of destigmatize what we already consider them or what society has already viewed them as. And so what advice would you have for USC students to get involved in these initiatives, and what can we do to further help?
So, wonderful question. If you have an interest, definitely educate yourself. Unfortunately, with a lot of curriculum here related to healthcare, you don't get the curriculum you need. So some of it you have to educate yourself. Find a good mentor who's in this space. Don't be afraid to ask questions. Don't be afraid to push back, because if we don't push back, it's going to stay the same.
Yeah.
Be cognizant of the current policies. Just educate yourself in that aspect. Make sure that if you do decide that you want to go into this field, that you are being reflective about it, that you are doing self-care, because it can weigh on your soul a lot, especially seeing people at their worst and seeing how they're living. So make sure you're being good to yourself. And ask questions. Always ask questions, whether it's in class, whether it's with colleagues, whether it's with mentors or mentees. Ask the questions that you want to get answered in this field, and make sure that you are doing everything you can to be the best clinician for the people that you serve.
Say that again, because that is amazing. I think that's awesome advice for students at USC, but not just students. I think everybody at USC can do all these things to help. You don't have to be a healthcare provider to educate yourself on the things that are going on in society. And I think we as a community need to take the initiative to start doing that more, to also, again, destigmatize, to break down these walls, break down these barriers that we have, or, and the way we view these individuals.
Definitely. And at the end of the day, we're all people. So
right.
Treat people well.
Yeah. I also like the point that you made about checking in with yourself, especially if you're around these people, because I think so often we are working, and we're not necessarily checking in with ourselves mentally, how we're feeling, what we're going through, because what they're going through can also take a toll on you. So I like that advice. And I think that's great advice. We'll probably link some information to this podcast if anyone wants to get involved with these initiatives at USC. I want to thank Dr. Terry Church for joining us today on this podcast episode. I hope the audience finds it as illuminating as I did. Again, thank you for being with us today.
Thank you for having me.